that time of the season, and all through the house, everybody's doing something, playing ball outside, they're making music in the living room, a little mischief in the den. It's good to have everybody home again.
I'm going to spend only 30 minutes of the time, and I'm going to try to go over what is stroke prevention. Since we are in a small group, we can do it interactive. And please feel free to stop whenever you want and ask questions, okay? The reason why a stroke is important is because it's a common condition. You can see that about more than 500,000 people suffer a stroke every year. And particularly, a stroke is now almost 700,000 people suffering a stroke. And in the year 2010 or 2020, 1 million Americans will suffer a stroke every year. And that is as a result of the growing elderly population. Means a stroke has a lot of things in common before you hear of a cardiovascular disease. And the problem is that the stroke leaves many people which are disabled, unable to function, and the cost, the economic cost, as well as the social cost is extremely high. They say that about $40 billion cost each in a stroke per year, which means a lot of money. Now, over the past 10 years, a few things very important have happened. We are starting to understand how to prevent a stroke, as well as how to treat a stroke in the acute phase. Up to 1996, we didn't know how to treat an acute stroke during the acute phase. Now we know. We can give TPA. I'm not going to concentrate on acute stroke, and I'm going to go mainly over stroke prevention. This is what I already mentioned. A stroke has also something important to keep in mind. The effects the prevalence of a stroke or the incidence of a stroke is different according to race. For instance, in the south of United States, it's called the stroke belt. Means that includes the African American population and Mexican Americans. In Texas, we see quite a lot of strokes in younger people than usually you will see, and with a stroke which are called lacunar strokes, very tiny strokes. The other thing is that, for instance, patients who have Asian population tend to have more intracranial stenosis. It means the vessels inside the head, they are more narrow than in the neck. White population is more in the neck than intracranial. It means if we do know those facts, I think we can better understand and prevent the stroke. Now, how do we divide a stroke? A stroke can be divided into hemorrhagic, when there is a rupture of an artery in the brain, and an occlusion of an artery. And that will lead to produce 60% are atherosclerotic, 20% are lacunar or tiny strokes, more commonly seen in Mexican Americans, Hispanics, and African Americans. Here is almost 30%. 15% they come from the heart, the cardioembolic strokes, and 5% are very unusual and uncommon causes. This is what a cartoon tries to show you. Regardless which artery is occluded, the result it will be the death of part of the brain, and that's in a stroke. The same as in the heart, it produces an MI, you have here in a stroke. This is the carotid arteries. The occlusion of these are very common, particularly in white population, atherosclerosis. Intracranial disease, little arteries occluded, produce tiny strokes, lacunar strokes. Now we understand that the aortic arc has a lot of atherosclerosis and also produce emboli that can block an artery. And of course, the heart, particularly with atrial fibrillation, is a major source of a stroke. Now, I'm going to concentrate in the atherosclerotic process, and that is mainly what happened in the neck. You know the process. We start with the buildup of the plaque that continues there are certain factors that are going to accelerate the atherosclerosis. Age, hypertension, genetic factors, hypercholesterolemia, smoking, and of course, there must be some other condition that we don't understand well. The end result is going to be an occlusion of this, or a little debris from here will go to the brain and producing a stroke or TIA. Most of the elements that start to stick together are platelets. Therefore, we should use antiplatelet therapy to prevent a TIA or a stroke. Means that's the idea, to prevent a thrombus formation. This is an angiogram, and what you see here is the common carotid artery. This is the external carotid artery, and this will go into the brain. The brain will be around here. And you see that suddenly there is a decrease in the lumen of the artery. It means there is a narrowing stenosis, quite critical. And that's what very commonly happens with patients who will have a stroke, or some of them are walking without a stroke. Those are called symptomatic or asymptomatic carotid stenosis. Now, we have to understand that there are certain risk factors for a stroke. Some of them we can change, others we can't. Age, we cannot modify. We become old and nothing to do about that. Gender, we cannot modify. Men, we do have higher incidence of a stroke than women. We cannot change. Hypertension increases by 5 to 10 times the risk of a stroke. Means we can modify that. Smoking increase also, diabetes, high cholesterol, and obesity. Means if we understand that, we can really prevent and make an impact on the incidence or prevalence of a stroke. Look what happened with hypertension. This is 30% of the people at age 18 do have called hypertension. That goes up to 55% when the patient reaches 55. And if you go above 65, about 70% do have hypertension. It means it's a common condition, hypertension. And the important thing is, several studies have shown that if you treat hypertension, this is the treated arm, and this is the one which was not treated, there is a 30% at least reduction of a stroke. Means hypertension should be treated, and at any age, from early up to when you are 80 or before you end up living. Hypertension should be treated, and that's the message, okay? The other issue is, well, this shows the result of several trials, and the average reduction was about 30%. Means there is no question that hypertension is a powerful independent risk factor for a stroke. Now, what about smoking? Smoking, again, is important. You see the prevalence, the relative risk of a stroke is here, and the number of cigarettes per day. Means if you smoke more, the chances to having a stroke go higher and higher. Now, if you stop smoking, the good news is that the chances of having another stroke, they're going to decrease. Means that's an important message for our patients. What about diabetes? Diabetes is a common condition, increases the stroke by twice, and also patients with diabetes, when they suffer a stroke, they do have a worse prognosis in recovery. Means we have to correct and prevent diabetes, not prevent, but at least to correct and adjust the glucose in that way to prevent the complications of this disease. What about cholesterol and stroke? It's very interesting that for cardiovascular disease, for heart attack, is a very well-established risk factor. For a stroke, was not well established until about 5 or 7 years ago. And when the more data start to come and show that really, if you lower the cholesterol, you are going to decrease the chances of having a stroke. But most of those studies, what they did is they took patients with coronary artery disease and they were randomized to a statin or no statin. And they found that, of course, the primary thing is decreases heart attack. But also, the reduction is about 30%. Means statins work. Now, we are doing one study, which is the first one, where we are comparing patients who had suffered a stroke. We are randomized to receive a statin versus non-statin. This is going to be the first study to prove or to say that was wrong, the prior hypothesis, that lowering cholesterol will prevent a stroke. What is a TIA? A TIA is a transient ischemic attack. That means it's a patient who presents with a left-sided weakness, and that recovers, most of them within an hour. That's called transient ischemic. It's a focal neurological deficit. TIAs usually by definition should last less than 24 hours, but most of them, they will last up to 20 minutes and up to an hour and a half. Why is it important to identify a TIA? Because someone who suffers a TIA is exposed to having a stroke now. The patient has a very high risk to suffer a stroke. Means a TIA is an opportunity to prevent a stroke. Therefore, we should identify those patients. If someone has a stroke, someone has a TIA, the chances to develop a stroke over 1 year is going to be 10%. Means it's very high. Do you have any idea what is the incidence of a stroke in someone who is 65 years old and has no risk factors, healthy? Any number, just tell me. No? No guess? If someone who has a TIA has a 10% of chances to have a stroke. Now I'm telling you someone with the same age, 65-year-old man, never smoke, exercise, no hypertension, what is the chances of the patient to probability to have a stroke? Oh, sure. It's less than 1%. Means you have to keep in mind that it's less than 1%. You have a TIA, it's 10%. You have atrial fibrillation, it goes up to 5%. You have atrial fibrillation and mitral stenosis, it goes up to 16%. If you have carotid stenosis plus symptoms, it goes up to 20%. It means those numbers is something we have to keep in mind. Remember, 1% approximately is 0.6, but 1% is a good number to remember for a healthy person who is 65 years old. Means this is an opportunity to prevent a stroke when we identify a patient with TIA. These are the symptoms how they present, but I'm not going to go over that. And how can we prevent strokes? Well, the first thing I was going through, control risk factors, hypertension, lipids, smoking. And we do have a number of drugs, antiplatelet therapies. And then we have surgery, which I will consider for some patients. The drugs that we have now in the United States to prevent a stroke, that's not cardioembolic stroke, not a stroke that comes from the heart, are aspirin, is the cheapest, very well-known drug, and reduces a stroke by about 20%. Then you have diclopidine, which almost we are not using due to the problems of neutropenia, which is another antiplatelet therapy. It will reduce a stroke a little bit higher by 35%. Clopidogrel, which is a Plavix, is a little bit better than aspirin. It's less toxic, and we use it for patients who are intolerant to aspirin and for those who were taking aspirin while they had a stroke. And dipyridamole and aspirin, this is a new combination which just came into the market in December, and it reduces the stroke, it seems to be above 25%. Means that's the Agrenox, they're doing a lot of publicity. What do we use in our patients? We use aspirin. Why do we do that? Because the cost is a very important issue. This aspirin will cost about, I believe so, I think it's going to be $1 per month, something like that, at the most. Any of the others will cost about $70 or $80 per month, which is a lot of money. And it's better to give to a patient something you can afford and something which is perhaps a little bit better, but the patient will discontinue the medication.
Tell me about the dipyridamole, because it must be a long time ago, because I'm pretty old. We used to use aspirin for Sandy.
Yeah.
That was what we used all the time. Then it kind of fell out of favor
Uh-huh.
because the studies weren't
Yeah.
good. So are you saying that there are now more recent studies
Yeah.
that are looking better?
That's a good point. Means you have two types. The era in the past, as you said, they have used dipyridamole alone. It's the persantin 75 milligrams. And aspirin, that's called azathioprine was called in the past. There have been several studies, at least some of them small and others which are called the European Stroke Prevention 1, where the results were negative. Now, the drug company, Boehringer, claims that in vitro, the extended release dipyridamole and the high dose, because before you were using 75 BID, now they say no, that's not the way it will work, because in vitro we see that the half-life of the drug is very short. Therefore, we need an extended release and higher dose. That's why in the ESPS2, which is where they try this drug, they use 200 milligrams twice a day of dipyridamole extended release, and they say the ideal combination will be a high dose of dipyridamole and a very small dose of aspirin. And they use 25 milligrams of aspirin twice a day. Means the end result was 400 milligrams per day of extended release dipyridamole plus 50 milligrams of aspirin per day. The results are very impressive. When you look at the combination, the reduction is 37% when you compare with placebo. And it's about 23% better than aspirin alone, the combination. Now, that study had two problems. The first one was conducted, analyzed, and executed by the drug company, and in Europe, where the standards are in some places a little bit different than North America. Second, they discovered that 400 patients were fabricated. They never exist in the database. An investigator, invented the name of the patient and said randomized to here and there. Well, the drug company, of course, found out that and say they took those 400 patients, and despite that removing the data, the study was positive. But one of the concerns that comes is why they waited so long, or what type of control the drug company had over the study, that after 400 patients, that means at least 4 years of randomization, they just found out there. Means that is one of the main concerns. Another issue is that, aspirin, clopidogrel, all of them, they work here, here, and here. Means when you look at the trials, aspirin reduces the cardiovascular death, the MI, the stroke, all together. The same is with clopidogrel. But the combination of dipyridamole and aspirin had no effect on vascular death. And that's one of the concerning things. Despite all that, FDA had approved the drug in January. And they're in the market now. And when people like you, they ask me, I just answer the most honest question. If you do believe the data seems to be the most effective drug, but there is a lot of reservation about that. And I just explained to you why.
Effective than
Clopidogrel. Oh, sure. Sure. This is only 7% above aspirin. The other is about 23%. No, there is no question.
Do you have that study, the reference?
Oh yeah, that was published. It's called ESPS2, European Stroke Prevention. Number 2 was published in, if you ask any of the Boehringer people, they will be happy to bring you even a card to you. It was published in the Journal of Neurological Science. I believe so, was November 1996. And the interesting thing is that they did not accept the publication of the study in Lancet. Lancet did not accept that. At the same time, you should look in December of that year, Science published something like the fraud had reached the clinical trials in a stroke, and they comment about that study.
Maybe that's why no one's really counting this study.
Well, but you will be having the Beringer people in your office, and you have to know that because you will have to make your decision sometime. I think keep in mind now the good part of this is that a very serious group of researchers from Holland, they're conducting a trial now where they are randomizing patients with a stroke or TIA to aspirin, dipyridamole plus aspirin, or warfarin. And they need, I think, 2,000 more patients to finish. But that's going to be the definitive answer. I think they will finish with that. If it's good, it will really work. If it's not,
Hopefully no patients that aren't existing.
yeah, certainly. Now, that's the idea with antiplatelet therapy. Now I'm going to move to what happened with a patient who has a carotid disease. This is a post-surgical endarterectomy. Means if you remove the stenosis from the neck, the idea is that you're going to prevent a stroke. And this is what a plaque of cholesterol with the ulcerated, with the ulcer there and a thrombus, fresh thrombus looks like. There have been several studies, one of them called the NASCET, where patients who had more than 70% stenosis and symptoms, like means TIA, numbness, tingling, or a speech problem, they were randomized. Half they received medical treatment, half surgery. Those who received medical treatment, at 2 years they had 26% the risk of a stroke. 26% of them suffered a stroke. Those who had surgery, only 9%. Means there is no question the reduction here was 15%. Surgery works. Now, you will see a lot of patients who had a problem in the neck, but they never had a symptom. And why do you find out? Because the doctor puts a stethoscope, oh, there is a noise there, a bruit. Let's do an ultrasound, angiogram, and they find disease. It's very common. Now what happened here is they did a trial for patients without any symptoms. And when they were randomized to the medical group, the chances to suffer a stroke at 2 years was about 2%. And when they had surgery, was 1%. Means surgery, the same as in the prior case, you remember here was 9, 26, a big difference. Here it still works. Surgery is better than medical treatment, but the difference only of 1%. I mean, what I have to tell you, the message is, this is symptomatic patients, medical treatment, surgical treatment. The absolute difference here is 15%. You have to treat 6 patients to prevent 1 stroke in this category. On the contrary, here this positive reduction is important. You have to treat about 50 or 100 patients to prevent 1 stroke. Means routinely we don't do surgery for asymptomatic patients. And that's the message. Now I'm going to move to cardioembolic disease. And cardiogenic stroke is about 15 to 20% of the strokes are cardiogenic. Perhaps are the most preventable type of a stroke. Why? Because you identify the problem in the heart early. Second, anticoagulation really works. It's very effective. Therefore, it's worth it to look and find those patients. Now, half of the cardioembolic strokes are due to atrial fibrillation. And atrial fibrillation is a very common condition. This is what you see in an atrium with a clot here, a thrombus, an electrocardiogram of a patient with atrial fibrillation. And just a brief comment that the mean age is 64 of people who suffer atrial fibrillation. More than 2 million Americans do have atrial fibrillation. And about 35% of them, they're going to have a stroke during lifetime. Means it's worth it to look at atrial fibrillation and treat those patients to prevent a stroke. Now, several trials have been done where they compare nothing versus warfarin. And the reduction is very impressive. It means you use warfarin and you reduce by 70% the chances to having a stroke. There's no question that the warfarin works. Aspirin has been also compared with placebo in patients with atrial fibrillation, and aspirin also works. Of course, the magnitude of benefit is not like the 70%, it's 25%. But for some patients who cannot tolerate the warfarin because has problems, we should consider the use of aspirin. And the message is that atrial fibrillations, the prevalence, it goes up with age. And also the paradox is that the risk of intracranial bleed or intracerebral bleed with warfarin, it goes higher with age. Means we have a higher risk of a stroke in this population with atrial fibrillation, and at the same time we have a higher risk of intracerebral bleed complicated or intracerebral bleeds due to anticoagulation. Now, the idea is that some patients, not every patient with atrial fibrillation do have the same risk. And that's why we classify patients with high risk and patients with no risk factors. If you have someone with atrial fibrillation alone, who is younger than 65, who has neither of hypertension, prior TIA stroke, diabetes, or heart failure, the risk of a stroke is 2% per year. It's pretty low. 1%, someone normal, this goes to 2%. Now, if you start to put any of those risk factors, it will go above 7% per year. Means keep in mind, and if a patient had suffered in a stroke and has atrial fibrillation, the risk goes up to 12%. Means it's important to stratify. Not every patient has the same risk. And then we say, well, what about if we treat patients with anticoagulation according to their risk of a stroke? Someone who is an unselected patient, you said, I'm not going to do any stratifications. In order to prevent a stroke using warfarin, I have to treat 33 patients. Someone who has a low risk, we have to treat 83 patients. But when you treat 83, you increase the chance of hemorrhage because 1% of them, they will have an intracerebral bleed, and 60% of those bleeds are going to kill the patient. But however, when you have a high-risk patient, you need to treat 16 patients to prevent a stroke. Means the message here is, if we can select our patients to give the appropriate treatment, antithrombotic medication, either aspirin or warfarin will be the ideal. Perhaps for this patient, low risk, aspirin will be ideal. If the patient likes to do a ski, if the patient doesn't want to be checking the INR every 2 weeks, aspirin will be ideal. For this patient, well, I think I will try to explain clear the risk of a stroke, because you are going to prevent, you treat 25 patients to prevent one disabling stroke. That means it's important in those patients the appropriate anticoagulation. Means the final message is that a stroke is a complex condition, it's a syndrome. You have 10 patients with a stroke, each one of them are different. We have to understand risk factor management, and we have to stratify the patients. And in order to prevent a stroke, it's a team effort between the patient and the physician, and understanding the pathophysiology of the stroke. I like this cartoon because it's not only doing one thing, we have to do several things. We have a patient on aspirin where we have to educate about smoking, lipids, and the rest of the things. I will be happy to answer any questions, and that's all what I have to tell you.
Well, it's that time
Do you have any questions?
of the season.
Thank you for your attention.
And all through the house, everybody's doing